Dear ladies and gentlemen, good morning. So as I can see, the most active participants in the conference are already here today, and we're beginning our first plenary session, which is focused on the future of HIV prevention, diagnostics, and treatment from process to results. Myself and my co-chairs, Vinay Saldana and Sharon Loon, are happy to welcome you in this hall. We're going to listen to some very important speeches today. 4 of them are devoted to various type of effective prevention of HIV and AIDS, new types of partnerships between public and private space. Therefore, if you do not mind, I would like to hand over to our first speaker, Mr. Vadim Pokrovsky. He will elaborate on the obstacles to effective prevention of HIV/AIDS. Dear ladies and gentlemen, I'm happy to see those of you who had an early wake-up today and who always attend plenary meetings. And those of you who have attended our second day, you must remember that we have heard such words that we are not reaching the desired target in the area of prevention and response to HIV, and the growth of new cases keeps on being at the same level, so it's not going down. So it seems that there are some barriers or some obstacles to effective implementation of the programs that are underway. So it seems so that there are some barriers. Therefore, when I was asked to make a presentation at this session, I started investigating, and I found out so many obstacles that we can keep on talking and talking for ages about them. Therefore, I will touch upon it, but will not delve into details. So let me go through some typical issues associated with obstacles that we face when we do our job. UNAIDS is defining obstacles in the following way: lack of political commitment, unwillingness to resolve some sensitive issues. So all these obstacles are drawn to one point of someone being reluctant or someone being unwilling to do something. But let us go further. And here I want to show you a quote of Mr. Fukuyama in his book, Powerful State. He put down the following wording: although a considerable part of our response to AIDS is an issue of resources, another important aspect is a capability of the government to implement healthcare programs. When the government needs to decide where to spend money, military, defense areas, they take a lot of money. Therefore, fight for peace is one of the most critical components which can pave the way for better healthcare system support. Around 30 years ago, I had a feeling that it would not be a formidable challenge for us to overcome HIV. This is my personal quotation 25 years ago when I said that HIV infection is an overcoming disease. You need to reduce the number of intimate partners, preferably up to 1, use condoms, do not inject drugs, and the epidemic will stop. So this is what I thought about it 25 years ago. But the reality is absolutely different. For example, one of the first points in time when we had in our programs, we learned that condom is one of the most efficient prevention tools. But why humans do not always use condoms? We know the objective reason: lack of information, first of all, do not know how to use it, do not know that condoms exist at all. But this can be resolved through education measures. Another reason is that they do not have access to buying condoms, or sometimes they do not have money. But this is also the barrier which can be overcome due to resources. When we start talking about whether we are efficient in promoting condoms, I would say that in Russia only 2 or 3 people who can in public show condoms, and then they receive a lot of criticism because someone say that they're showing condoms in order to prove that they are potent, not to do another thing. But why is there such big public resistance? Maybe tradition, modesty, or some other points related to the mindset. I do not know. We can see that there is a proactive, like, sort of unsupport of condoms. There are such things circulating in the public space that condoms do not protect from HIV and other infections, saying that there are some holes in the condoms. And another concept which is circulating about condoms, they say that condoms are hazardous for the health of individuals. So these concepts do not have any scientific evidence. You can go and Google a lot of evidence which proves another thing. What we have this opinion that has been voiced by Vladimir Zhirinovsky, and you never understand whether he's joking or saying truth. He says, if condoms do not protect us from AIDS, then why should we use it? This is what he said, and Zhirinovsky is a high-ranking politician in Russia. Well, there are even some scientific and mathematical foundation to it. And among people who have doctoral degrees, they say that if condom protects from HIV only at 90% of cases, then it means that every 10th sexual intercourse can lead to HIV infection. And therefore, if a person had 100 sexual intercourse, even using condom, he will definitely get infected. So we also see such kinds of opinions and understand that that's ridiculous in terms of any scientific evidence. But for a common person, when he reads or listens or hears such opinions, he believes them. Some people say that condoms are lead to smaller birth rate. Well, this is the opinion which is popular among groups who are interested in higher birth rates. But there was an interesting situation, I remember, in Southern Africa. There were black nationalists who said that condoms are imposed to us by the whites in order to reduce our head count of African population, and this is a trick on the side of white people. Therefore, we definitely do not need to use condoms. And you know, in Russia, there are activists who are combating against condoms. And they say that we have here Western agents who are propagating the use of condoms for Russian population to go down. Well, this is all ridiculous, of course. Another behavioral approach that say that condoms can indulge incorrect or hazardous sexual behavior, or can apologize you if you sexually sort of misbehave. Another facet of condom blaming, something related to egotistic and hedonistic motives. People saying that if we using condom is the same as smelling a flower through some barrier or through some hurdle. So, and another motives that are related to some social Darwinism story. What is social Darwinism? In particular, it's related to eugenics and selection of more pure races, and it's one of the philosophical pillars of Nazism and fascism. And they believe that the more gay people and the more sex workers are infected with HIV and die from AIDS means that there will be a better, higher quality selection of population. There are also some opinions voiced saying that HIV infection is the punishment for misbehavior. Therefore, the more people are infected, the less bad examples for the rest of the population will be present here. I have also heard such opinions, but at our first plenary session, the representative of the Russian Orthodox Church treated it in a different way, and I believe that he said that it is not a punishment any longer, but a challenge for us, at which we need to pay attention, on which we need to focus, so that we need to change our behavior as the society. However, religious and moral motives in their traditional format are still here. They are still on the table, and among Catholic population, there is an opinion that if a condom prevent conception, it means that they prevent the fulfillment of the Lord's ideas. And on the other side, the Protestant people, they are more calm about that, and they say if a Lord has an idea, then the conception will be performed even if a condom is used. So it's a philosophical issue which I believe deserves a separate line of conversation. But I am always interested to listen our Orthodox evangelists, and I can see that we can move towards a trade-off, a compromise, and I have heard that using condoms is a lesser sin as compared to abortion. Therefore, I believe that we can reach agreement with the religious community in this sphere. However, all the motives that are standing behind the obstacles to effective prevention need to be studied, and for every motive that I have marked here in my presentation can also be similar to pre-exposure prevention tools, so they can face similar challenge in terms of different types of obstacles. However, no one has said anything against vaccines, although there is an anti-vaccinating movement ongoing. So, as I have mentioned, when I have started investigating into these types of obstacles, and yesterday, by the way, our colleagues have shown flowers and parts of the flower, and each part of the flower can provide for effective prevention, but only if they work together as a comprehensive set, we can account for an efficient result. But as for the program which stands behind every part of it, it is facing some sort of challenges. Therefore, I believe we need not only to be based on some rational point of view, but also try and analyze irrational approaches, so that we can make our tactics in a more efficient way. Thank you. Okay, dear ladies and gentlemen, if you have any questions, I think we now can have a chance to give you the floor for a question. Please approach the mic. No questions to Mr. Pokrovsky, and I would like to give the floor to Sharon Lewin, who is director at Peter Doherty Institute for Infection and Immunity, and she will talk about progress towards an HIV cure, current clinical strategies.
Thank you very much and good morning. Thank you to the organisers for the kind invitations, especially to my friend Vinay from UNAIDS. It is an absolute pleasure to be here. It's my first time in the beautiful city of Moscow, and it's been fascinating to hear about the different challenges facing you here in the prevention, treatment and care of HIV. Today I'm going to take you to the future about whether we might one day find a cure for HIV. But before I start, I want to emphasise that we have the tools now to stop HIV transmission and to end deaths from AIDS. And this should in no way be stopped or slowed down in waiting for a cure, because as passionate as I am about finding a cure, we have a long time to wait still. So over the last 2 days, you've heard lots and lots of different strategies of ways to improve prevention and treatment and all the wonders around antiretroviral therapy. So I'm going to start by putting to you why we do need a cure for HIV and why we need to be investing in a future where we one day might have a cure. Well, the first reason is that antiretroviral therapy is excellent, but there still is ongoing drug toxicity. In addition, we know that there is persistent inflammation and accelerating ageing on antiretroviral therapy, which still needs to be addressed. Many individuals living with HIV, as in many other chronic diseases, have pill fatigue, so maintaining lifelong adherence to treatment is a challenge. In this country, more than any other country, we know that there is still significant stigma associated with living with HIV infection. But probably the biggest reason about why we need to invest in a cure is the global financial burden of lifelong ART. And it's estimated that it will cost $25 billion a year by 2020 in order for us to achieve the UNAIDS targets by 2030. And 40% of that cost is secondary to antiretroviral therapy. So although we must continue to emphasise the need to invest and support treatment and care, we need to think of a way to, in the future, not have this financial burden. So I'd like to start by defining what we're trying to achieve when we talk about cure. And in preparing this talk and in conversations with the translators, I realised that the word cure is quite complex in Russian. And some of the translators told me they don't have a similar word. But what we mean by potential cure or eradication is that there is no virus detectable in someone living with HIV, or what we would say in English as a classical true cure. We know this is going to be extremely difficult to achieve for an infection such as HIV. What we now know is that remission may be a far more achievable goal. And what do I mean by remission? For the physicians in the audience, this is similar to how you might think about in cancer care. In the setting of HIV, remission would mean that the virus is at low but detectable levels off antiretroviral therapy. An individual would still therefore be HIV antibody positive, but would remain well, and most importantly, the transmission risk would be zero. Now, we know that there's only been one individual truly cured of HIV infection, the Berlin patient, or Timothy Brown, who achieved a cure through transplantation, not a viable strategy to implement for the 37 million people living with HIV. So the goals of cure research currently, and this may change in the future, is to find a way to achieve remission, or a way that people could stop antiretroviral therapy but maintain the virus at low levels, stay well, and not transmit the virus. Now, in research, how might we define HIV remission in a clinical trial? And at the moment, the only way we can determine if someone is cured or in remission is by stopping antiretroviral therapy, which I know many of you will be aware is not a good thing to do clinically. But in the setting of a clinical trial with regular monitoring, this is now a common endpoint of cure studies. So in the black line, you can see what happens to the viral load when you stop antiretroviral therapy. Virus will rapidly rebound, usually within 2 to 3 weeks, and will remain elevated. So one outcome of a clinical trial is to see a delay in viral rebound, shown to you in a blue line, a measurable time where there is no detectable virus, and potentially the virus may come back in months to years or decades, a little similar to how you might think about cancer remission. The alternative endpoint is to achieve something that we now call post-treatment control, shown here in the red line, where an individual would have a brief period of viremia, but then control the virus at a far lower and safe level. And both of these outcomes are acceptable outcomes for what we're trying to do in cure research. The big challenge, though, is that we have no biomarker that can predict the time to rebound or post-treatment control. And until we have such a biomarker, treatment interruption is really the only way we can determine if some of our interventions are working. So I'd now like to just very briefly explain to you what the major barriers to a cure or remission are, so you can understand some of the interventions that are being tested. Now, the major reason why HIV persists in people on treatment is something called latent infection. It was discovered back in the late 90s that HIV can enter inside a cell and effectively go to sleep. And it's shown here to you as a cell with a green box on the inside, but the virus is not actively replicating. And therefore, the cell is not seen as infected by the immune system, and the antiviral drugs can't attack the latent virus. We've known for a long time that latency is established in long-lived cells, and it's established very soon after infection. So within days of infection, you have this pool of latently infected cells. Now, over the last few years, we've also learnt that these latently infected cells can proliferate, so they're constantly maintaining a pool of these long-lived infected cells. And together, this is the big barrier of what we refer to as latency. In addition, we know that that some cells can persistently produce virus, or what we now call the active reservoir, shown here in red with virions leaving the cell surface. And in the active reservoir, any virus produced can't go on to infect new cells because an individual's on antiretroviral therapy, but those viruses are still available to rebound once someone stops treatment. Where do these cells sit? They sit predominantly in tissue sites, in lymphoid tissue, in the gut, and in the brain. And in recent studies performed in monkeys, we know that really most of that virus is sitting in the lymphoid tissue, shown there as the red dots, and secondary amounts in the gastrointestinal tract, and very little virus in other tissue sites. And this means it's very difficult to access these long-lived, latently infected cells. So it's a bit like the babushka dolls. HIV reservoirs on treatment are really complex, and we keep finding more of them the harder we look. So we have a big challenge ahead of us. So what are some of the ways that we might achieve remission of antiretroviral therapy, and what's being investigated currently? This is summarised in the slide here, and I'll take you through each of the strategies and give you just a few examples of recent clinical trials of those strategies. So in the top left is virus elimination, ways to get rid of those bits of virus that stay in hiding, either by waking that virus up or putting it permanently to sleep. There's a lot of work being done on gene therapy, which is literally using gene scissors to excise HIV from the genome or get rid of the receptor that HIV needs to enter a cell. Over the last few years, there's been a really big effort around building or restoring immunity, allowing for long-term control of HIV with either vaccines and antibodies or immunotherapy. So what about if we treat people really, really early? Could we ever prevent latency being established? And for a long time, we've known that early treatment leads to a decrease in the reservoir, the amount of virus that goes into hiding. But recently, from some fantastic studies done in Thailand, we've also learnt this will lead to a delay in time to rebound, but unfortunately will not cure HIV. So this diagram shows you again the viral load, this time in a blue line. If you stop antiretroviral therapy in someone that started treatment in chronic infection, which is essentially 99% of people living with HIV who start treatment in chronic infection. And you can see that on average, this is from historical studies, virus will rebound within 14 days. If you start treatment during acute infection, what I've called here Phe-big stages 3 or 4, which is usually within 6 months of infection, you dramatically reduce the reservoir, but virus still rebounds, and really a trivial sparing of rebounding within 22 days. And if you start treatment in really, really early infection, literally within days to weeks, so what we call Phe-big stage 1, where people are RNA positive but antibody negative, disappointingly, you cannot eliminate viral rebound. So early treatment alone has some benefits. It has benefits in preserving immune function. It has benefits in reducing transmission, but it will not be a cure for HIV. Now, many of you would have heard about these rare case reports, such as the Mississippi baby or the Boston patients, or a recent patient from San Francisco treated in very early infection, who have a very delayed time to viral rebound, sometimes as long as 24 months. Now, these people are extremely rare and most likely occur because you have a tiny amount of latent virus that stays very silent and then will intermittently or randomly reactivate, and that may take a very long period of time. But these are the exception to the rule. So if early treatment can't get rid of virus, what about some other strategies? And one strategy that my own laboratory has worked on for many years is this idea of whether you can eliminate or reverse latency, something we call shock and kill. So here's the latently infected cell, the cell that we're after in order to cure HIV. And the idea here is that you would activate that cell to convert the latently infected cell into a productively infected cell using something called a latency reversing agent. And usually when a cell starts producing virus, it will die. Or alternatively, you could combine this with something to enhance immune-mediated killing, or a pro-apoptotic drug, a drug that drives cell death, commonly used in treating malignancy. And all of this would be done in someone on antiretroviral therapy, so any new virus that you produce can't go on to infect any other cells. And we now have many latency reversing agents that are active in vitro. They tackle all different pathways to stimulate the virus to start to replicate. And many of these agents have gone into clinical trials, shown in the dark lines, clinical trials that are completed, and in the dotted lines, clinical trials that are ongoing. And ones that are completed included histone deacetylase inhibitors and disulfiram, and drugs called TLR agonists or toll-like receptor agonists. Unfortunately, or fortunately, all of these drugs have shown that latency reversal is possible in vivo. However, none of these studies have shown that you can eliminate the latent reservoir or induce cell death. And so there's now lots of work being done to find more potent latency reversing agents, or whether we can use these in combination to eliminate those cells. Oops. I think the studies so far have shown us that we can't just tackle the virus alone. We need to also be boosting immune function to allow long-term control or remission. And probably the most promising approach currently is using something called broadly neutralizing antibodies. And these antibodies actually have multiple roles in both prevention and potentially cure. So what is a broadly neutralizing antibody? Well, some people living with HIV are able to make very powerful antibodies that don't just recognize their own virus, but can recognize hundreds of different viruses. We can actually identify the cells in the body that make those antibodies, grow them in the laboratory, and make large amounts of these broadly neutralizing antibodies. And there's over about 200 antibodies described, and some of them are listed here for you that have gone into clinical trials. And they're being tested in HIV prevention, as HIV therapeutics, and in cure studies. And studies to date have shown that if you give someone infected with HIV on treatment a broadly neutralizing antibody, you can delay that time to rebound or allow for prolonged suppression following interruption of antiretroviral therapy. At the moment, though, broadly neutralizing antibodies need to be given as an infusion, so they're not a great advance over long-acting antiretroviral therapy unless we can work out how to generate these antibodies by vaccination. There is increasing evidence as well that these antibodies can potentially eliminate infected cells, and they may even boost T-cell function by acting as a vaccine. And this is the only real data slide I'm going to show you. I think it's a really exciting new study done in monkeys that was presented earlier this year at CROI. It comes from Dan Baruch's lab, where he gave these broadly neutralizing antibodies to monkeys on antiretroviral therapy, together with another drug called a TLR agonist, or a drug that activates cells or activates the virus. And I'm showing you here the viral rebound after stopping antiretroviral therapy. And in the top left is the placebo arm, so every animal that stopped antiretroviral therapy had viral rebound. In the upper right panel is the TLR agonist alone, where about 90% of monkeys rebounded. In the lower left panel is the antibody alone, where about 90% of animals rebounded. And in the lower right, you can see when you give the two interventions together, only about 50% of the animals rebound, and all of them actually go into remission. So these were very, very exciting data. They admittedly just show that potentially we can cure these monkeys. I should add, though, that these monkeys are are infected with a weakened form of HIV, and it may be a quirk of the monkey model, so we have to see whether this is possible to repeat in humans. A little bit harder to move into humans. We need to know the antibody is safe. We need to know the TLR7 agonist is safe, and then we can put them together, and those studies are ongoing. Finally, there's a lot of really exciting advances in the cancer field, an area we call immunotherapy, ways to strengthen the immune system against cancer through something called immune checkpoint blockade. And very briefly, what do I mean by that? Well, in cancer and in HIV, the immune system gets exhausted and it starts expressing these markers called immune checkpoint markers. If we give an antibody that blocks that immune checkpoint marker, and here's an example of an exhausted T cell meeting a cancer cell expressing PD-1, if you give the antibody anti-PD-1 to people with cancer, you can reinvigorate the immune system, and the oncologists are seeing spectacular successes with this drug. We've known for a long time that in HIV, we also have exhausted T cells, and HIV-infected cells express these exhaustion markers as well. So there's a lot of interest in immune checkpoint blockers in the setting of infection, particularly in the setting of HIV infection, and those clinical trials are now currently underway in people with HIV and cancer. And once we know that this is safe, we could potentially do the same studies in people with HIV without cancer. So in closing, I want to leave you with the message that there's a lot happening in cure research. This is an area we need to invest in as a global community. But a cure is likely still decades away, and it's very likely a cure may only work in a subset of people. We hope to have something like antiretroviral therapy, but that may not be possible. So in the meantime, I remind you that treatment is really the only thing and must be offered to everyone living with HIV. Access to lifelong antiretroviral therapy and care for every person living with HIV must remain a top priority. I want to finally remind you about the AIDS 2018 conference in Amsterdam. There'll be a lot of cure research presented at that meeting. And on the Saturday, July 21st, we will have a session on cure, a whole-day session on cure, particularly targeted towards community. But even for scientists and physicians that have little background or understanding of cure research, this will be a really accessible way to learn about the current advances and controversies in the field. The main conference will be translated into Russian, so I really encourage you all to attend. And finally, I just want to end by acknowledging many of my colleagues from Melbourne, collaborators from across many other countries and funders, and thank you again for the opportunity to present to you. Thanks very much.
Огромное спасибо.
Thank you very much, Professor Lewin. In spite of the fact that you underscored very many times during the presentation that the complete cure, HIV cure, is, let us say, probably not the thing of tomorrow, but what we've heard, the developments that you highlighted, gives us a lot of hope that it's still possible, that it's foreseeable. And if there is anyone in the auditorium who wants to ask questions, you're most welcome. Not because Professor Lewin is present here, but it's really easier to ask questions now than to go to Australia, because it's a bit far away. That's why, if you have questions, take this opportunity. We have a few minutes for Q&A session.
strategy, that is immune elicitor cytokine gene expression towards the potential HIV integrated DNA.
I'm sorry, could I just ask you to repeat the question? I couldn't hear it.
What do you think about the strategy that is immune elicitor cytokine gene expression towards the potential HIV integrated DNA elimination?
I'll just repeat the question for the audience. I was asked about a strategy using cytokines, which is another arm of the immune system, to access or eliminate HIV latency. I think that is definitely one of the approaches that is being tested. I mentioned one cytokine called interleukin-15, which may well have a action on both activating the virus and also activating the immune system. So I think we're still at the stages at the moment where we need research, understanding the biology of why HIV persists, and new things to test. And I think that's one of many, many things being tested currently.
Do you believe if you increase the gene expression of the immune-related cytokines like IL-2, interferon gamma, the set of cytokines, will it be useful to stimulate the CTL to immune-mediated killing of the virus-harboring cells, that is CD4 cells or whatever the virus-harboring cells? And can we get towards the potential cure if we work it on in this strategy?
Yeah, I'm a bit reluctant to get into too much technical detail given the audience here today wanting an overview of cure, but I think the principles that you outline are consistent with what I talked about, trying to reduce the virus and trying to stimulate the immune system, and very happy to discuss the details after with you.
Yeah, thank you.
Еще желающие есть? Пожалуйста.
Что вы думаете о новых препаратах, которые сейчас исследуют?
So what do you think about needle injections that will soon be introduced to the market? So it should be like one injection per 8 weeks or within several months. The mic was not working. I didn't catch the first part of his question because the mic was not working.
Antiretroviral therapy that is being developed currently for both prevention and treatment, and many of these agents may require as few injections as every 2 months or perhaps every 3 months. I think long-acting antiretroviral therapy will be a great advance to give people living with HIV more choice about the optimal care that will suit some individuals. I don't think that the long-acting antiretrovirals will have a role in cure. And the main reason is they will act in the same way as the oral tablets do, and they can suppress virus beautifully, but they can't eliminate latent forms of virus. But I'm actually very excited about long-acting antiretroviral drugs. I think they will give us more choice for both prevention and for cure. For prevention and for treatment, but unfortunately won't play a role in cure.
My question is about what do you think about those tissue reservoirs which are not targeted by ART? For example, it is known that at the beginning of the asymptomatic period, 98% of viral particles are located on the surface of the follicular dendritic cells, and this tissue reservoir is not targeted by ART. And also, it is well known that in this tissue reservoir, viral particles, even covered by neutralizing antibodies, remain infectious for a long time. It was shown by the Professor Gregory Barton in the United States. And what do you think about other possibilities how to target this tissue reservoir, because it is well known that in sooty manga bays and in African green monkeys, interestingly, there are no viral particles on the surface of follicular dendritic cells, and maybe this might be a lesson which we might learn how to reduce this reservoir or even eliminate. What do you think about all these points, please?
Yeah, I think that's an excellent question, and I think that that's really where the problem is sitting currently, inside tissue. And I think there's a few advances we need. It would be great if we had much better ways to quantify virus in tissue. At the moment, it's really difficult because you need to do a tissue biopsy and only get a small amount of the tissue. And there are some exciting new ways, perhaps using imaging or PET-CT scan to actually quantify how much virus is in tissue. And you raise a really good question about virus sitting on these cells called dendritic cells. Some of the strategies being tested is using nanoparticles that might allow greater tissue uptake of antivirals. And the other strategy is using ways to get the immune system inside tissue better by disrupting those tissue follicles, which you can do with some immunological strategies.
And interestingly, I just would add that actually in the future, in the near future, there might be also an interesting strategy how to neutralize such infectious particles on the surface of follicular dendritic cells. And now I'm currently working on such possibilities. Yeah, thank you very much.
Great, thank you.
Если нету больше вопросов, тогда мы переходим.
Unless you have no more questions, let's then give the chance to speak to the next speaker, Mr. Masur Dara, who is Coordinator, Communicable Diseases, Division of Health, Emergencies and Communicable Disease Program Manager, Joint TB HIV Viral Hepatitis Program at WHO Regional Office for Europe. He will elaborate on the ways towards achieving sustainable development goals in the Eastern Europe and Central Asia.
Colleagues, thank you very much, Vinay. Thank you, organizer, for this opportunity to talk today on sustainable development goals and what needs to be done further. Actually, as you know, in 2000, the heads of the states got together and decided actually we need to do the things differently on the new era, which is called Sustainable Development Goals. So there was a lot of discussion and dialogue. As you know, we have 17 different goals. And of course, very important for us is Sustainable Development Goal 3, which is talking about the health and well-being. Now the question is that what do you want to do differently than before, obviously. We are looking at more broader areas that are having impact on health. We have different action plans, as you can see on the picture, but how we can make sure that these action plans are reaching the targets that we want in our region. As you know, the core business of the Sustainable Development Goals is leaving no one behind, and that's extremely crucial for our region, particularly, as you know, prison services, migrants, as well as also people living with HIV, homeless people, poverty, and also socially marginalized population, and also injecting drug users. These are the population that we should also take into account when you look at the response to HIV and other diseases. Now, during the conference, we heard from many distinguished speakers in terms of how we are doing in the region. Talking about the WHO European region, we have 53 member states, which include Western Europe, but also Eastern Europe and Central Asia. Every year, together with the European Center for Disease Control, Prevention and Control, we collect the data, we published. And last year, during World AIDS Day, we focused on the area of the late diagnosis, which is very important, and I come to that one later. Basically, as you can see in the numbers, we are having a huge challenge in terms of increasing number of HIV infection. And look at the sub-regions, Western Europe, Eastern Europe, and East. and more than 80% of all these new infections are in Eastern Europe and Central Asia. Our focus, as I mentioned, was on late diagnosis, meaning people coming and presenting with HIV with CD4 count or more, less than 350 cells per cubic milliliter. And that's major challenge, basically, in our region that we have. Looking at also the 1990, just as a reminder to all of us, we have a huge discrepancy in the region. The numbers above is showing you the average in the WHO European region, 53 member states. The below numbers are the numbers showing the Western Europe. And you can see Western Europe is almost reaching the 1990, while we are having huge challenges in the region as a whole, but also particularly in eastern part, where only 2/3 of the people with HIV are being detected, and as well as also less than half of them are antiretrovirals. Another important element is tuberculosis. As you know, we have only 3% of the burden, global burden of tuberculosis in WHO European region, but we have almost 20% of the burden of multi-drug resistant TB in the region. And that's extremely important to consider, because once you have a multi-drug resistant tuberculosis, which is very difficult to treat, with almost half of them successfully cured, also combined with HIV, you'll have a recipe for disaster. So there are two numbers that I would like to remind you on that one, is that 1 out of every 5 person living with having multi-drug resistant TB is in our region. The other important number is that every 1 out of 5 new TB patients in our region have multi-drug resistant tuberculosis. Now coming to TB-HIV co-infection, as you can see on this slide, we have 1 out of 8 people having TB having HIV co-infected. But also, as you can see, we have a rise of the TB-HIV co-infection in the last couple of years. The numbers, the percentage you see is the average of the region, but on the other hand, we have also differences in the countries, particularly 2 countries, Russia Federation and Ukraine, where about 20% of all TB patients are already HIV co-infected. Now, as I mentioned, what needs to be done differently, which direction should take further to have this Sustainable Development Goal 3, which is good health and well-being. First of all, we should sustain what we have been doing. So it's meaning that we have to continue the work that we have been doing under the MDG, Millennium Development Goals, but also address the health inequities. If you remember, I mentioned the populations are left behind. We should not leave anyone behind. We need to have accelerated actions, and of course, fast-track approach is important. Also, fast-track cities initiative is important, but also very important under the SDG to address the determinants of the health. What are the reasons some people have more vulnerable, and how we can address those vulnerabilities? And of course, very important, universal health coverage, as you know, achieving the overall health. We have been very proud in our region, which is we've been the first region with malaria-free, so that we don't have any indigenous transmission of malaria. We are polio-free since 2002. We have been also doing a great job in terms of increasing life expectancy in our region, with more than 77 years life expectancy, and of course, with the differences that we have in the region. Also, lots of progress on the non-communicable diseases, but still, in terms of communicable diseases, particularly HIV, we are doing very bad. Now, I put this slide because that's extremely important in our region. Many of our countries have been receiving Global Fund support. By transition from Global Fund to domestic resources, very important to make sure the medicines are affordable and reaching the people that is needed. Very important also to mention that if you look at the national budgets, a great proportion of expenses are on medicines. We have something from 10% to 30% of the expenses of the country's budgets going to the procurement of medicines. So that's also called for more coordinated, concentrated approaches in order to have the medicines affordable for our countries. Very important to put people on the center. Of course, science is important, but also public health calls for that, getting the people on board with designing the services that are people-friendly, user-friendly. Very important also the integrated care. In our region, we have vertical specialization, which is also important and needed, but on the other hand, making sure that people are not having very long trajectory to go from one services being detected on TB, going to the other services for HIV, and vice versa. So we need to have also more integrated care. So overall, we need to have more intersectorial approach, engaging all the stakeholders, working on health system strengthening and universal health coverage. Very important, equity and human rights are a crucial element on the SDG, and also sustainable financing. Financing which is not only domestic resources, but if needed in terms of private sector engagement, and also research, and very important to monitor where we are and how we are going forward. I put this slide in terms of the our regional action plan. You know, in 2016, we had the Ministers of Health endorsing this action plan, which is calling for several areas that needs to be done in our region. And don't go through this because you're familiar with this action plan, but very important that the three areas of the innovation interventions for impact and also delivering for equity and also financial sustainability, all three of them are in line with universal health coverage. So the other element that also very important that we need to make sure that we have the roadmap that we have for the Sustainable Development Goals that was endorsed. I don't know if you're familiar with the regional committee, but this is a platform where the ministers of health get together every year and they discuss what are the top priorities for the region. And last year, they endorsed a roadmap to implement the Sustainable Development Goals, meaning going more, working with other sectors to address the determinism of health, but also accelerating efforts on health. This was endorsed at the regional committee, but also very important that in terms of once you have a resolution or commitment, to be able to monitor implementation of it. And in terms of monitoring implementation, obviously there are several areas that we can work on that one. Very important, of course, the World Health Assembly resolutions and committal documents, but also at the regional committee where the ministers of health are coming to see whether the progress are. And very important, of course, the UN General Assembly. As you know, we had already several sessions on health, on HIV particularly, AMR, non-communicable diseases. And this year on September 26 will be the first ever UN General Assembly on tuberculosis. And of course, that's also very important because at the level of heads of states, the issues of the tuberculosis will be discussed. So with those words, actually, I would like to thank all colleagues who contributed, but also mention that we need to really accelerate our efforts in our region and move forward. Thank you very much.
Спасибо, Масуда.
Thank you very much, dear Masood. Any questions to Masood?
Remind on the issue-based coalition on health, because that's what I forgot to mention in my presentation. Together with other UN agencies, we discuss in terms of, these sustainable development goals are quite heavy item. How you want to translate it. It's very nice in terms of wording, but how it's going to change the lives of people in the countries. And what the UN in general can do. So we had series of discussion, almost like 10 months, discussion with the different colleagues from UN agencies, UNAIDS team, UNAIDS and colleagues, UNICEF, UNFPA and others. So we came with this conclusion that we have to have kind of common position of all the UN agencies. Meaning that it's not only the health, ministries of health, but also going the education, foreign affairs, migration, and all the other sectors, as well as the private sector NGOs. So we developed a common position paper, which is going to be actually launched on 9th of May by all the regional directors in Geneva, where they're going to meet. And this document is basically kind of was on public consultation. Some of you also contributed to that one. It is not another action plan because we have enough action plan. It's another resolution. We have enough resolution. It's basically bringing all of us together how to address the things as a common UN. And now you may ask, what is the added value of another paper? Is that the idea is to go to countries and then start with few countries, getting around the table all the different sectors and NGOs, and start to have a truly SDG approach, a sustainable approach, development approach to HIV, TB, and viral hepatitis. And if the colleagues would like to, I would be happy to share that document also with them.
Спасибо, Масуд.
Thank you, Masood. Any questions at this stage? Okay, so then I would like to hand over to our last speaker, Jacob Andriozzi, who is Vice President at VIIV Healthcare. He is one of the strategic partners in the conference, and he's also one of the most positive examples of what we call public-private partnership in healthcare. So you have the floor. Good morning, and this is all for my Russian.
Thanks to Vinay specifically and Professor Voronin for the kind invitation. As a disclaimer, the slide said I'm a full employee of VIIV Healthcare. And I share with Sharon the joy of being here at ECAC, that's my first ECAC, and see the progress in the science, but even more importantly, the progress that has been made in the region. And I agree with Professor Prohorsky, a lot still needs to be done. There are still a lot of hurdles, but certainly a lot of progress when it comes to policy and when it comes to implementation step to change the epidemic of this high-burden region. And what we believe, and that what my presentation hopefully will try to show, is that we at VIIV Healthcare, but more general, the pharmaceutical industry can play our part in changing the shape of the epidemic, not only in this region, but globally. So what we share as well, and that's what Dr. Dara was mentioning before, with WHO, obviously with very distinct roles, is our commitment to the mission of leaving no people with HIV behind. And the way we believe we can achieve that is these three pillars that you see on this slide on our strategic intent. Number one, we are trying to establish integrase inhibitor at the core of HIV treatment. And why we want to do that? Not just because we are in love with our own molecules, but because that's what the data shows. In 20 years in the industry, I never witnessed or had the pleasure of working with medicine that have demonstrated superiority against all gold standard, whether it's non-NRTIs, whether it's protease inhibitors, and even other integrase inhibitors in the same class. And that's what dolutegravir has demonstrated. And that's why this has been reflected in WHO guidelines, in Russian guidelines, and in guidelines across the globe. And that's why dolutegravir is today the most prescribed integrase inhibitor in the world and the most prescribed core agent in many countries across the globe. And this has been recognized, as I said, also on day one by Dr. Irnschall, the director of the WHO HIV program, and will be reflected, as he anticipated, in changing in the guidelines of WHO, upgrading dolutegravir as a first-line preferred treatment for patients across the globe. What we do, we don't stop here, and that's what the second bullet on the slide shows. We want to advance continuously HIV research and development. And we do that by studying dolutegravir in underserved populations that are very relevant for this region. And I'm thinking about women, I'm thinking about children, I'm thinking about co-infection with tuberculosis, and we have studies showing efficacy and safety in these populations. And also in patients that fail efavirenz as a first-line treatment, which once again is very relevant for this region, but also for sub-Saharan Africa and other developing countries. What we want to do also, based on the strength that dolutegravir has shown, is to move the bar even further. And that's studying dolutegravir as a two-drug agent instead of a triple combination. If two drugs can do the same job as three drugs, why using three? And that's what we're trying to show, and actually that's also what Sharon was referring before. In the long-acting agents, we actually have a combination of two drugs for treatment and one single drug, cabotegravir, for prevention, as was mentioned before. We're also looking for solutions for patients that are running out of options. And that's one of the reasons why we purchased the discovery unit and the pipeline of our competitors, BMS, by adding the attachment inhibitor in our portfolio, attachment inhibitor that has shown recently very encouraging efficacy in heavily treated patients that have failed multiple classes and therefore are really running out of options. So that's really our commitment in R&D at 360 degrees for the whole world. Finally, and that's what the third bullet on the slide, ViiV is also very much about partnership. That's actually also what it says in Russian there. You have sponsors, and sometimes we are fine with being sponsored, but we also have partners. And that's, let's say, our preferred model is about partnership. And there is a number of reasons to that. So while we have a lot of expertise and passion about this disease in our company, as the only company fully dedicated to HIV, we are a small company. We're a company of 1,000 employees compared to some of other companies, including, for example, our parent company, GSK, that is close to 100,000 employees, just to make comparisons. Not only, but our expertise is, not surprisingly, to discover, develop, and commercialize HIV medicines. So we cannot do everything by ourselves. We don't want to do everything by ourselves. And that's why we partner with different institutional, academic stakeholders, and partnering together, we try to contribute in addressing this terrible epidemic. So on the left, we partner with funders, we partner with patient groups and other community groups to better understand the disease through insights and support activities that can make impacts in communities across the globe. The second column, obviously for those that are not Russian-speaking, we partner with academia, not surprisingly, with researchers like Professor Lewin, with clinicians like Professor Perkowski, Professor Voronin on the panel, and many more across the globe, to fund, support, and partner in preclinical and clinical research that addresses the unmet need of the disease understanding and unmet need, obviously, from a medicine standpoint, and hopefully one day, as Sharon was telling us, a cure. But at the end, and then clearly, we need to partner with governments and other supranational, like UNAIDS and WHO, to support different efforts, sometimes, and I will come with an example later, being in the driving seat, sometimes being more in a supporting fashion, support efforts to address the epidemic in individual countries and globally. And finally, we need also to partner with other manufacturers and other companies, again, because we are quite small. For example, ViiV doesn't have our own manufacturing site. We don't manufacture our own medicine. We use Shionogi, one of our parent company, Japanese company, to produce the API, the active pharmaceutical ingredient of dolutegravir with high quality. We use GSK, another parent company, to manufacture the finished product in different countries across the globe. And we use also GSK to distribute our product in many countries, including in Russia and in the region more in general. We even partner with companies that otherwise are competitors. In this slide, you see Janssen. We partner with Janssen to develop that same combination of cabotegravir and rilpivirine, which is a Janssen molecule that we were alluding before, that one day, hopefully, will provide a long-acting treatment that with just one injection a month or one every 2 months will be able to control the virus. So that's what we do, for example, with Janssen. And I'll come back later on, for example, what we do with a company like Servier. But before I make this concrete example, let me tell you a little bit about our general approach to access to medicines, because that's very important in general, but even more important for this region. What you don't see on this slide are the highly developed markets, the markets where we make the majority of our profit, like the US, like Western Europe, Japan, Australia, and so forth. Those markets are extremely important because those are the markets that allow us to continue as a business, to make a profit, to reinvest part of that profit in research and development, in continuing to look for new medicines, but also allow us to fund some of the initiatives that I'm going to mention now that make access to our medicine broader than just in the developed world. And that's what really this slide is about. So what we do, especially in developing countries and especially in sub-Saharan Africa, we still file broadly from a regulatory standpoint. So we try to get regulatory approval for all our medicines. And this 100 that you see here is the number of countries where we have regulatory approval for dolutegravir, for TVK, so dolutegravir standalone. And why we file in countries that we know we will not compete commercially, because that's the way to pave the way for generics to piggyback on our registration and register their own molecule in those countries. And that's really primarily our model in sub-Saharan Africa. We don't have the scale and we don't have the ability of competing with price and with scale of manufacturing like Indian company has or some of the Chinese company. So we give our intellectual property, that's what the second bullet says, with voluntary license. To this date, 17 different companies have received this voluntary license, and sometimes we even help them with tech transfer so that they can piggyback on our registration and come into those markets and provide dolutegravir and other products in a way that is with a scale that is a log magnitude compared to what we could do, and obviously a competitive price that those governments can afford. So that's what we do in developed markets. And by doing this, and that's what the third bullet there says, we are able to cover in those countries 94% of the adult population and 99% of the pediatric population through these licenses with generics. Finally, and very important for this region, what we do in upper middle income countries is a tier price approach, which is based basically on 2 things. One is GDP per capita, so how much a country is able to spend, and we use World Bank definition, which is, it is what it is, but at least it is an objective parameter. But the other thing that we take into consideration is the burden of HIV. Because GDP tells you something, but of course, if you are a country with very high burden of HIV, a lot of your spend will go on HIV, and therefore we try to take that into account. But at the end, it's about tailored solutions for individual countries, and that's how we are able to provide access to our medicines in upper middle income countries, like some that are represented in this region. So let me come back to this couple of examples that I was mentioning that can make this even more clear. This is about Brazil. Brazil, obviously, not in this room, but certainly a very good example on how you can introduce a medicine like dolutegravir on a large scale through partnership. So what the top left is showing is that we have been partnering with the Brazilian government to be able to find a solution from a price perspective that would allow dolutegravir already in 2017 to be the preferred agent, so a little bit ahead of WHO guidelines, for all naive patients. At the end of 2017, there were already 80,000 patients treated with dolutegravir in Brazil. And what you see there in the picture is the Minister of Health of Brazil and obviously Dr. Irnschall sort of sealing this new adventure between the Brazilian government and ViiV with the WHO approval of the fact that this was an important step for Brazil to control the epidemic. What we also do, and that is on the top right, is to scale up our manufacturing capacity to be able to support such a strong epidemic and such an ambitious program. And what you see there is the pallets of the first shipment of over 100,000 packs. Eventually, we shipped more than 1 million packs in 2017 to Brazil, reaching the warehouse of the Brazilian government in Brasilia. Also, what we've been supporting the introduction of dolutegravir in the country is with medical education. It's fundamental because Brazil had limited experience with integrase inhibitor and even more limited experience with dolutegravir. Therefore, we partner with physician association to make sure that the data is understood, the risks are also understood, and anything that has to do with a large-scale introduction is appropriately managed. And actually, some of the results are shown in the bottom right corner, which is a poster that the Brazilian government has presented, completely independent data, at CROI Congress in Boston this year about the experience on the first close to 30,000 patients that were observed. This is a surveillance study covering these patients and showing low incidence of side effects and low incidence of discontinuation in this large-scale introduction in first line. Obviously not comparable data with clinical trial because this is surveillance, it's not a clinical trial. So this is Brazil, but also we have very good news, as many of you know, coming from Russia, where dolutegravir, together with many other medicines, 13 medicines coming from ViiV GSK, are now available and included in the essential drug list for the Russian government. And dolutegravir is actually seeing the introduction as we speak, with the first shipment of dolutegravir in the federal program coming to Russia now in April. Other important parts of the partnership with the Russian governments and with the Russian academic community is shown on the bottom left corner, and these are clinical trials. We believe Russia has a very important role to play when it comes to clinical trials. The epidemic is significant, the patient populations are important for the type of study we are running, and therefore we have 8 studies as we speak running in 18 separate centers across, as you can see from the map, the Russian territory, and that's a commitment that will continue with the ViiV and GSK to bring new molecules, including cabotegravir. There are studies ongoing with cabotegravir in Russia, in the Russian territory, and keep partnering with academia for this important element of the partnership. On the top right corner, another key element of the partnership, an element that is very close to the heart of the Russian government, localization of manufacturing. The ideal, that's one of the vision for 2020, is to have more than 80% of medicines produced in the Russian territories for Russia. And we decided to partner with Servier, a French company, but with a manufacturing facility here, south of Moscow, Servier Rus, to produce dolutegravir here in Russia. We are waiting for regulatory approval in Q3 this year, and we should see the first Russian-produced packs of dolutegravir coming to the market early 2019. So that's really a critical element in our partnership. And finally, what you see on the bottom right corner is partnering with media to support efforts at federal, but even more important, regional level on understanding of HIV, on addressing all the issues that, or some of the issues that you have heard from Professor Pokorski in his talk in the beginning. Final slide, and then I'll close. These two initiatives that you have seen, or different elements of our partnership in Russia and Brazil, ViiV is primarily in the driving seat. We are working, obviously, with multiple partners, but this is mostly, not only, but mostly about our medicines. In other occasions, what we do is to partner with existing initiatives, more of sponsor and funders, and that's what we've been doing with UNAIDS and with IAPAC for fast-track cities, which has been mentioned a couple of times in this talk and throughout the Congress. Fast-track cities, as the name says, is trying to accelerate the response to HIV in municipalities around the globe with high burden of disease and many problems when it comes to intravenous drug use, sex workers, and so on, that often are more concentrated in the cities. What ViiV does is really supporting data collection by sponsoring a number of dashboards that the cities are putting in place to make sure that they look at the 1990 response at city level and look at what type of initiatives in the community at city level and sometimes at provincial level, depending also where the budget are, how these are progressing and changing the shape of the epidemic in these cities. There are many cities around the globe that have signed what is called the Paris Declaration, because this initiative was kicked off in Paris, and commit to supporting these radical changes and acceleration of the response at individual city level. Kiev in Ukraine has been part of Fast Track City already for 2 years. I believe Almaty in Kazakhstan is also part of the Fast Track City. What we're waiting impatiently for, and UNAIDS is waiting even more impatiently, is that Russia comes also to the table of fast-track cities. They are having conversations with St. Petersburg, they're having conversation with Moscow, they're having conversation also with other important cities in Russia with high burden of epidemic like Ekaterinburg and so forth. So that's something we hope we'll see, and ViiV is committed to continue sponsoring and supporting this initiative. So if I can conclude, this has been a little bit about we do this, we do that, and of course I want to reiterate that nothing that you have seen in the previous slide could be possible without the partnership that ViiV and his industry partner has with supranational organization, with government, with patient advocacy group, with academia and clinician, especially in countries with high disease burden like this. So basically my message to ourselves and to other industry partners that might be in the room is that we can retain our nature of being a profitable business, but in a way that is built on science, that is built on data, and that is built on ethical partnership with key stakeholders that can make an impact on the epidemic. So thank you.
Thank you, Jacopo, for a great presentation. It just struck me about the excellent things both academia and private sector are trying to do around innovation. I guess that was a common thread with both my talk on cure and your talk on treatment delivery and access. And it struck me hearing Masoud's, really chilling statistics around the difference between Western and Eastern Europe and this real need to do things differently and to innovate here. And some of the thoughts I had were, opportunities around thinking of new ways to deliver prevention and treatment here, opportunities around clinical research. And I just thought I'd make one comment about the Fast Track City initiative. Melbourne is also a fast track city. We're not a city with a high prevalence of HIV, but we certainly still have a significant community of people living with HIV. And although in our healthcare system treatment uptake is high, our biggest challenge has been around testing and preventing new HIV infections. And the Fast Track City initiative gave us a fantastic platform for partnership with government, and I think had a really important role in introducing point-of-care testing and most recently PrEP, which is now funded across Australia. So we've used it to leverage our relationship with government, and that's been incredibly helpful. And finally, I just might add that even in a country like Australia, the people living with HIV who are co-chair the Fast Track Cities with me still highlight stigma as their biggest problem that we need to address. So all of us have a big challenge, and all of us need innovative ways, not just around prevention, treatment, but also this ongoing problem of stigma that really exists everywhere.
Уважаемые коллеги, пожалуйста, вопросы.
Any questions? Okay, so now we see. Good morning, Anatoly Reshinov. I'm from Belarus. I have a question to Mr. Andrioza. So you mentioned criteria based on which VIV selects countries that can be included into the license, and based on which they get into patent pool. We are the patients. We know what capabilities are existing in our countries because we undergo this treatment. And in Belarus, for example, there is significant shortage of dolutegravir, for example, and other integrase inhibitors. We have sent our request to Deborah Waterhouse with a request to make to invite you so that you can make assessment, because a high rank of the country in terms of the World Bank is due to some other Soviet legacy, but we want private company to come and make your own assessment, because Gilead included Belarus in the licensing countries. So this is my request, maybe kind request to you, and a question to you.
Thank you for the question. See, I'm absolutely aware of the dialogue that is happening between community partners and even Belarus government and VIV. We are open to discuss solution with the Belarus government, something that we made the Belarus government aware. So I'm sure this will happen. And we are talking about finding a solution when it comes to flexible pricing for Belarus, similar to the ones I was describing for other markets. And that's something that we prioritize.
Thank you. Any more questions? No more questions. I would like to say, firstly, big thanks to all our speakers. Thank you so much for raising interesting questions and interesting topics. A round of applause to you. And big thanks to the audience for coming here, for listening. See you at the next session. Thank you.